Good afternoon. It's a great honor for me to have Professor Kasivisvanathan from London, UK. Hello, Veru.
Hello, Pavel.
Another game-changing study, PRIME. Congrats.
Thank you very much.
Could you tell us more about the study itself, about the design and objectives?
Yeah, so PRIME was an international multi-center diagnostic study assessing whether bioparametric MRI without contrast was non-inferior to multi-parametric MRI with contrast in the detection of clinically significant prostate cancer in men with suspected prostate cancer. The background to the project was based on the work in the last 5 years where multi-parametric MRI has become standard of care. Since this, there has been a challenge in healthcare centres being able to meet the demand created from the change in guidelines promoting MRI. So we wanted to offer a solution and evaluate a shorter, more streamlined scan which didn't involve a contrast injection, saved 10 minutes off the scan, and was quicker and cheaper. And if we showed that that shorter, more streamlined scan was as effective as the more detailed multi-parametric MRI, we hypothesized it could become the standard of care.
Thank you very much. And what are the key findings of the PRIME study?
So critically, we found that the clinically significant cancer detection rate was very similar between the multi and the biparametric MRI. So biparametric MRI was non-inferior for clinically significant prostate cancer detection at around 29% for both arms.
So actually, does it mean that we can omit contrast media in all patients, like around the world, and stop doing it?
Yeah, really good question. So the most important thing to emphasize before we drop contrast is that the quality of scans in this study was good. Before centers took part, they had a quality control phase and had to achieve a PI-QAL score of 5 in some scanners to be able to take part. So the radiologists were generally experienced. So to say that we need to drop contrast, we can definitely generalize those conclusions to centers with good scans. For centers with not so good scans, maybe we need to do a little bit more work on quality improvement first.
Okay, so basically we should still do contrast if we are not sure if our scans are, I would say, very good quality.
Yeah, what I would say is assess the quality of your scans first. If they're good quality biparametric scans, then you can apply the findings of our study quite easily. On the converse side, when you look at the totality of evidence, when we looked at precision and the quality control from precision, that was a study in which centers' MRIs were not optimized.
Okay.
And contrast was the least well done sequence when you have non-optimized scans. So if you have a center with poor quality scans, it's probably, in my opinion, less likely that the contrast helps you than if it's a good quality scan. So the rest of the evidence would support that biparametric MRI without contrast would be something that would be the standard of care, but we should be cautious about applying our findings beyond the patients we examined in this study.
Yeah, because sometimes it's also like related to the patients. It's not like even the technique itself. So I really wonder if we can really we 100% sure before that we go only with biparametric or so how do you suggest to handle things like this?
Yeah, so there are other things that we looked at which were important in deciding whether or not you need contrast. Before we designed the study, we were quite confident that contrast would play a role in influencing what treatment options you give a patient and how you give those treatments. For example, in radical prostatectomy, whether you nerve spare on one side or the other, whether you do a bladder neck spare, and for focal therapy, what type of energy source you'd use and how much of the gland you treat and your margins. When we looked at this in the study, we actually did a central multidisciplinary team meeting without the contrast, making those treatment decisions and planning decisions, and unblinded after revealing the contrast and remade those decisions. And we found that contrast influenced what treatment options a patient got in about 4% of cases and how you deliver that treatment in about 3%. So maybe overall there wasn't as big an impact in terms of treatment and management of a patient than we thought. So that's another component to the discussion.
And okay, so basically, but do you still believe that we need contrast, for example, in the recurrent setting or during active surveillance, or it's end of the story? Now we only do, we should do.
Really good question. So we only examined the primary referral setting for men with suspected prostate cancer. So we cannot make those conclusions beyond that. In the recurrent setting, for example, contrast is really important. We know that. An unanswered question is, if you don't have contrast to start off with, how will that affect your determination of recurrence, say in a focal therapy setting? So active surveillance is also a separate setting, and so we cannot draw conclusions to those settings based on this.
So now the final question: when we can expect the publication of the prime trial?
Hopefully the publication will be along in the next few months.
Okay, so thank you very much for your interview. It was great pleasure, and we actually, I would say, now understand much more. Thank you very much.
Thank you, Pavel.